Hi, this is Dr. Piyush Bhargava, and I have a few interesting cases to share with you. So, our first patient has an aortic graft, and they were evaluated with a CT. They were suspected of being infected. And here on the CT images, on the early images, we see abnormal soft tissue around the aorta. And so, this is the graft. Posterior to that is their native calcified occluded aorta. And on the delayed images, this abnormal soft tissue enhances. There's also some fluid around this aortic graft, and this aortic graft is also seen here on the sagittal image. So all these findings suggest that there is aortic graft infection. Patient underwent a whole body FDG PET CT. Here is the rotating image, and we see mild to moderately intense FDG uptake at the site of abnormal findings on the CT. And so this is seen right here, the aortic graft with surrounding enhanced soft tissue and fluid. It is showing FDG uptake suggestive of an infected aortic graft. This is a good review paper on aortic prostatic graft infections, radiologic manifestations, and implications for management. Our next patient was being evaluated for a neuroendocrine tumor and underwent a gallium-68 dotatate PET CT. And so here on this rotating image, we find physiologic distribution of the tracer and a focus of uptake in the right upper quadrant of the abdomen that looks like this on the fused axial image, and right here on the sagittal and the coronal images. So is this a neuroendocrine tumor? Well, it turns out this is gallbladder activity. So these are two good papers on this topic. The one on the left, titled Physiologic Biodistribution of Gallium Labeled Dotatate in Normal Subjects, they don't talk about gallbladder activity. They didn't see any gallbladder activity. But the second case report where these authors saw gallbladder activity on a lutetium-177 dotatate post-therapy scan say that the lutetium dotatate may be excreted into the bile, and they saw gallbladder activity. And from the days of doing indium-111 octreotide scan for these neuroendocrine tumors, we know that there can be excretion of tracer from the liver into the gallbladder. So be aware of that caveat or artifact. Our last patient has advanced prostate cancer. They presented with rising PSA, and on this whole body image from their F18 labeled PSMA study, we find that they have extensive metastatic disease. This is their primary, arising from the left peripheral zone of the prostate and then metastasizing to the pelvic nodes, and then higher up para-aortic retroperitoneal nodes, and then we see multiple foci in the bones. So a good case representative of metastatic prostate cancer and a good candidate for lutetium-177 PSMA therapy. This is a good article on the role of PSMA PET CT in the primary diagnosis and follow-up of prostate cancer patients. Thank you for watching.